Dr. Kline, good to see you.
Good to see you, Parker. How are you?
I'm good. Thank you for coming to Kansas City.
Thank you so much for having me. It's wonderful out here. Food's fantastic.
Oh, you had some barbecue, we had a fun day in the lab.
Absolutely.
Just a fun day all around. So thanks for being here.
Thank you.
Yeah. So we had a conversation earlier about how you work together with your PAs in your practice. And I love the teamwork and the camaraderie that you guys have and how you identify patients. So can you just tell me and our audience here how you guys do that? I thought it was really intriguing.
Well, thank you. Well, I've got two fantastic PAs, Nick and Miriam, and they see almost all the follow-ups. Really, I see all the new patients, and I do all the procedures. And so the way our practice runs, there's really no way. We've got 11,000 patients in our practice, and so there's no way that I could see every one of these. But so our goal is that when they see these patients and they identify they've already gone through a certain gamut of very conservative therapy, and they're not continuing to improve, what is our next step? So the PAs are very instrumental in ordering MRIs and things like that, so we can determine if there's another procedure that can help them. And so once they've ordered the MRI and we say this patient has certain symptoms, like they've got some sacroiliac disease that we treated with steroid injections has not gotten better, so we order studies to see if those have significant degeneration, that we can maybe do a minimally invasive procedure to correct that permanently, or if they've got spinal stenosis, lateral recess stenosis, things like that, then maybe they're a candidate for a Minuteman.
I love that. And then I want to transition in the conversation to your own personal experience. The interventional pain market is evolving, and it's been evolving, especially the last 5 to 7 years.
Unbelievably.
Yeah, and I know you've been doing this a while, so take me through your own experience, 5, 7, 10 years ago to where it is today.
Okay, well, when I first began doing interventional pain management, we had a certain number of things that we could do.
Yes.
Mostly steroid injections, epidural steroid injections. We do sacroiliac joint injections, facet injections, radiofrequency ablation, all those things. And once our patients had run the gamut of those procedures, then we would say, okay, well, we're not making continuous improvement. What do we need to do? So we get a surgical consult. And so the patient may have been a surgical candidate, however, due to other comorbidity, they may not been able to undergo the surgeries. So we would have to do things like a spinal cord stimulator. Spinal cord stimulators could help those patients, but it wasn't necessarily the best treatment. Now with the evolution of procedures like the Minuteman, where we can now do a procedure under just heavy sedation, which can correct spinal stenosis and neurogenic complication. It's amazing. The same thing with the Liberty. It's just a small incision, heavy sedation, local anesthetic, and they're in and out in no time. So it's been really a game changer, and it's made pain management so much more interesting to me than it was before.
I love that. Thanks for your time today, Dr. Kline. Great to see you.
Thank you, Parker. Always a pleasure.
All right.